Well, thank you very much, Dr. De La Hoz, and for everybody else who's attending. This is a project that's been a multi-year project involving the fire department, Mount Sinai researcher, and of course, we have the World Trade Center Health Registry. So it was something that we had conceived maybe 5 or 6 years ago, that our individual cohorts would not be big enough to actually detect relatively rare outcomes. So we began the process of thinking about how do you combine the cohorts that already existed and put them together in a way that we could actually learn more, perhaps, than individual cohorts could ever provide. So that was one of those challenges in occupational health. It takes years to actually come to fruition, but it actually happened. So that's I think, a major accomplishment right there. This is a list of all the different grants and cooperative agreements. Of course, many of them are not possible in the future. So it's a sad commentary that this will be very difficult to do in the future. So the question that we were faced with, to begin with, why do we need to study mortality in the first place? Isn't it too early? I mean, basically, mortality is, of course, a very long-term endpoint. So does it make sense to even ask the question when you're talking about people who were relatively young when they entered the cohort, most of them? Of course, it's a age range, but would you expect to see anything? So that's one of the questions we always need to ask when you start a big project like this, is why are we doing this? And what about, of course, we knew there was something called the healthy worker effect. And this is a very, very highly selected population. Particularly the rescue and recovery workers, for example, for the fire department, are screened. And they have very careful monitoring. So are we likely to be selecting a group of people that are super healthy to begin with, which again means mortality is probably not something you're going to see changes in very soon. And how about the effect of interventions? Let's say we do a big intervention. Would you expect to be able to see it in this cohort, in effects of mortality? And the intervention, of course, is the World Trade Center Health Program, which has provided screening, treatment, no cost, additional cost treatment. So that's a major intervention. Would you expect to be able to see the effects of that intervention this early? And then there's always a problem in epidemiology. What are you comparing to? And in the case of mortality, it's a very important question, because your comparison population determines the denominator in your studies. So we have to think about, well, what's a good comparison population for a group of relatively healthy, highly selected rescue recovery workers? Is the general population a good comparison? Probably not. So what do you use? And you need a population big enough to be able to give you estimates of mortality. So those are all challenges that we had to kind of overcome to even begin this project. But we persevered. So I'm hoping at the end of this, you'll be able to think about 3 reasons why we should do this study in the beginning, why study mortality in this group, and be able to maybe use the formula for a standardized mortality ratio. You probably studied this in public health school, but if you haven't used it since, it might be a little rusty. So I'll just go over an example and give you some, at least, outline of what that involves. And then I hope you can describe the healthy work effect and think about why it might be occurring in this population at this time. and compare and contrast the options for a comparison population. Because again, that's key to any epidemiologic study. So everybody here is very familiar with the exposures we're talking about. These are exposures that range from the building itself collapsing, the dust, all the things that happened in 2001, 2002 with cleanup, transportation of the debris to brush kills, landfill, sorting of the remains, taking things to the morgue where they're still being studied. And the stress is pretty incredible. Stress by itself, has that any kind of relationship to mortality? Oh, well, that's a controversial topic, but yeah. And then there's the complex exposure mixture for individuals. We don't have measuring devices that were available to see what actually people were exposed to. So getting exposure into this picture is, again, another one of those challenges in epidemiology, and particularly occupational epidemiology. If you don't have exposure measurements, you're relying on self-report, which is largely what we ended up using. So there are different exposures, as Paul Lioy and the group from Rutgers identified. There was, of course, the first category of people who were there immediately after or during the collapse. Then there's a period of burning and fires extended until really December. And then after that, of course, there's debris removal with lots of dust being regenerated. And so it was a hazardous work environment. So why, again, answer the first question I asked you about why study mortality. Well, I think there's certainly, and I've adapted some of the slides from Paolo de Pofetta's talk. He gave a talk on this topic for the NIOSH Research Symposium. So I'm borrowing some of his slides, and this is one of his slides that talks about an ethical imperative. Here's a group of people that really were highly exposed, and it raises a question which we had to think about very soon after we set up the registry. For example, the World Trade Center Health Registry, within 5 or 6 years, we had to begin thinking about setting up ways to measure mortality. And I think mortality, again, is one of those endpoints in occupational health it's clear, it's documented, there's no argument. So that's part of the ethical requirements, I think, of following a whole group of people into the future. And then answering the scientific questions, what does short-term high-level exposure do in terms of risk for mortality? And what does long-term follow-up mean in this kind of disaster? We also know a lot of the substances that we think were there, we know were there, don't have a known latency or time induction period to cause long-term health effects. That was something we noticed in the literature. There's really no good literature on a lot of the things that were there about how long does it take to show an effect. And then what are the impacts of the intervention in the World Trade Center Health Program? Can we see there's an effect this soon? If so, that would encourage continuing the program or expanding the program. And then finally, what about building collapses and fires? Fires are becoming a much bigger issue, of course, with global climate change. We're going to see a lot more fires in the future. Fires are a big part of the World Trade Center exposure. So can we learn something from this exposure that we could maybe apply to other settings given the future disasters? There were first attempts to study mortality. The first one was done here at Mount Sinai by Dr. Stein, and it looked at the general responder cohort in up to 2016 data. Or no, actually the data was only up to 2011. So you're talking about 10 years of data. And they had a standardized mortality ratio of 0.43. That means this group is a highly selected, very healthy cohort, so they're dying at the rate of about a half of what the general population rate is. But mortality was not they did actually try to look at exposure and see if it was associated with those people who did pass. And there was no evidence of exposure associated with mortality. So should we continue? You got this study, says everybody's dying at half the rate. Is it worth continuing? Well, we continued. We looked at our cohort at the registry, and we had follow-up. It was another 4 years. So add more data, you potentially can see something. And we did find that SMR now is 0.69. So there's something going on. Maybe it's going up. However, we did see a 40% elevation in all-cause mortality risk in the responders who had high versus low exposure. So this is, if you will, the first clue that there maybe is some thing that's going on. We looked at self-reported arrival date, duration, and location of work. And then there was a follow-up. The FDNY did their own mortality study. They did included data up to 2017. Their SMR was even lower than Dr. Stein, 0.34. That means the death rate in the fire department is about 1/3 of the general population. And again, they found they saw no relationship between exposure and mortality. So when you see a mixture of effects like this, what do you do? It begs the question, what's going on? So at that point, we decided that was about the point where we decided we had to pool these cohorts. We can't really do individual cohort studies anymore. Because really we're risking seeing anything at all. So the fire department, the responder cohort, and World Trade Center Health Registry, we all worked together and wrote all the IRB proposals. This is a simple graph on the right of all the IRB applications, data use agreements, all the partnership agreements. This is documented by Dr. Brackwell, how long this takes to do this kind of studies. Of course, it also involves a lot of other agencies and people. But we were able to merge the cohorts. What are the advantages of a pooled cohort? Well, you have a little bit more variety in exposure. You have independent recruitment. There's an open cohort here at Mount Sinai. There's a basically closed cohort at FDNY because they all were joined from the very beginning. And then there's the closed cohort of the registry. So you have a combination of recruitment. Maybe you can say something about more of a varied cohort. I skipped a slide. So the aims really were to look at a combined deduplicated cohort with 15 years of follow-up and look at, again, the exposure levels and see if they were associated with any of the outcomes. Deduplication is important. There are people that are in all our registries. So what would you do? You had to take the people in the FDNY and take the people in the GRC and the registry and see how many of them actually are in multiple cohorts. And indeed, the total was about 69,000 workers, of whom there were a fair number that were in multiple cohorts. So we were able to then subtract them and then put together a unique cohort of people that were being able to be then counted. And the person who did this was at the state health department in the cancer registry. So we had to have a kind of a neutral broker, if you will, to be able to identify make sure you have the identities of all these people. I don't want to know who's in your cohort. You don't want to know what's in the fire department cohort necessarily. So we had to have somebody that could put them all and deduplicate them. And we categorized the membership in hierarchical fashion. So we took people who were in the fire department, and even if they were in the registry and in Mount Sinai, we said they're in the fire department. And then people in the GRC were counted if they're not in the fire department and if they were in the registry, they still counted in the GRC. And then we were left with the registry. So the registry was kind of the last category. It had to be 18 years or older on 9/11, and they had to have race ethnicity information. And of course, that's an issue. You're going to lose. A lot of people don't like to fill out the race question and the ethnicity question. Some people stop at the ethnicity question, as Dr. De La Hoz is very familiar with. And a lot of people object to the whole question because they're multiracial and they don't fit any of the categories of our current scientific race categories, ethnicity categories. So that's a problem for FE research in general, but we do have data on most people. And there are people who died or reached 85. Amazingly, people, rescue recovery workers, were already 85 by 15 years later. So that meant they were 70 when they were out there on the pile. We also, that's our exclusion criteria. And we ascertained deaths using the National Death Index. And we did that individually for each cohort, and then we merged them. We took deaths from enrollment to end of 2016, and we categorized using the 28 categories that NIOSH has set up. Within their 119 cause rate file, NIOSH created this life table analysis system, LTAS. And of course, rest in peace, right? NIOSH is basically gone. So what are we going to do for the future? Most of the tools we have come from NIOSH. It's a very sad day, I must say. But they're grouped into heart-related, cancer-related, and tobacco-related causes. We looked at data of arrival from September 11th, 12th, between 13th, 17th, and then anybody between 18th and the end of June 2002. And we did know what they did on the debris pile, because each cohort did capture that data. And we did this analysis beginning with a standardized mortality ratio. We can look at the observed deaths compared to the expected deaths based on a reference population for all causes. And we also looked for each of the 28 major causes. And we accounted for age, sex, race, ethnicity, and calendar period. LTAS is a wonderful program. It does all this. We followed up time beginning 1 year after enrollment. But some people may have died from the trauma at 9/11 or other reasons. So we didn't want to muddy the waters, if you will, with those deaths that occurred in the first year. And we used reference rates from both New York State and the United States. Toward the end, we'll talk a little bit about what are the advantages of either one of those. So standardized mortality ratios uses indirect standardization. You probably remember from public health school, there's direct standardization and there's indirect standardization. Why would you use one or the other? Well, direct standardization is some way better, it's more accurate, but you need to know you have to know the rates in both your population of interest and the comparison population. Here, we don't know the rates in our exposed population. So that means you have to use this indirect standardization. And there are some other advantages. If you have small numbers of deaths in any of the specific categories, you can't use direct standardization. So that's another reason. This is not it's a big cohort, but it's still the number of deaths is small. And especially if you start breaking it down. So you take this formula, and it's the O is number of observed deaths in the stratum. You have to look at each stratum of age, and in sex, and in race. So it's a lot of strata. And then you divide that by the sum of all those strata in the comparison population. And you develop person years, that's PY, times the rate in the reference population, which is lambda sub I. So it's a really useful formula, but you can't really compare an SMR to another SMR. That's one of the disadvantages. That's one of the advantages of a direct standardized rate, is you can compare SMRs. But an indirect standardization, you can't because the reference population may be different. So SMR, you can't really compare to another SMR using the indirect standardization. So I've already described how to do this SMR. And here's an example using Los Angeles County, comparing the death rates in California. You have the age categories, like on the left, standard population death rate, as you can see. The kids less than 1 year old, their death rate is 5 per 100,000. You multiply those through your study population and you expect 8 deaths. And you do that for each strata, and you come up with a total 59,000 expected deaths. And the actual observed is 59,000. So standardized mortality ratio in LA that year, 2004, was 98.8. What does 98.8 mean? It's pretty much close to 100, or it's really the SMR is 1, you multiply by 100, but it's close to what you'd expect. What do we see in our population? We also did some statistical modeling using Cox proportional hazard modeling to try to look at exposure. You can't really look at exposure very well using an SMR. You have to use something like Cox proportional hazard modeling. And we did try to look at arrival date, work on the pile, see how I'm doing with time. We adjusted for sex, race, and smoking status at enrollment. And we looked at exposure, looking at exposure effects on cause-specific mortality. There's something called a proportional hazards assumption, which you have to check in the beginning when you do this. And if that assumption is violated, you need to change your method. So we had to control for age on 9/11. It violated the proportional hazards assumption. Mathematically, Cox proportional hazard model is shown here, where H sub Tx is the hazard rate at time t for an individual with covariates listed here. These are all the exposures that we want to look at. And then H sub t is the baseline hazard function when all the covariates are 0. And then B sub 1 and so forth, the regression coefficients for each covariate. And then we expotentiate it, and we get the proportional hazards. So it assumes the hazard ratio is maintained as a constant over time. So that's why age failed at that beginning process. That's why we had to control for age. Because of course, we can't really assume things are not going to change with time when you start with age. We had to exclude 8,400 from the combined cohort because of all the different exclusion categories. We didn't have their race, ethnicity. They were over 85, younger than 18. Analytic sample finally was 60,000, 15,000 from FDNY, 25,000 from GRC, and 19,000 non-FDNY, non-GRC. That's the World Trade Center Health Registry. It was almost all male, as we'd expect, 84%. Mostly white, 71%. Never smokers were about 60%. It's pretty healthy population. The average follow-up was 11 years, because people kept coming into your registry, really. That's why there's a shorter time period than the registry or FDNY. And we had 697,000 person years, and we accumulated 1,900 deaths. So what do you think right now? Is there enough data here to actually do something? Seems like it, right? It's a fairly big population. You've got a lot of person years. So we'll see. Is it big enough to actually see something? Well, we can see the membership here, total membership 60,000. It was broken down into the different cohorts. And this is a list of our exposures. It varied. As you can see, FDNY mostly arrived on 9/11. 21,000. I mean, 58% of FDNY arrived on 9/11, and some of them came later. And GRC, you can see, 35% were here. We're at 9/11 on, we're at the site on 9/11. And the rest came much later. Of course, there was a lot of the groups that are at FDNY are construction workers and people who worked in the cleanup and in the recovery. So, and the registry is about 18% were at 9/11 and pretty well distributed. You can see a lot of them came between September 18th and end of the cohort, the accumulation period, which is end of June 2002. So the cohorts really vary again on this key variable of when did you arrive. Tasks on the pile, FDNY 81% were on the pile, compared to GRC about a quarter, and the registry is kind of similar, around 20%. So there's a lot of variability again in the exposure by cohort, which is a good thing for epidemiology. We can actually see if there's a difference. The deaths, we can see that the largest amount of death occurred in our World Trade Center Health Registry. And you can see the distribution, fewest were in FDNY. Heart disease, of course, was the biggest cause of death across the cohorts. Well, actually, the biggest cause of death was tobacco-related disease. No surprise. And you can see the distribution of cancer, cardiovascular disease, and respiratory disease. Any surprises here? Not too much different than general population, I think. I don't know. It's a relatively healthy population. The SMRs, what do you think? Well, SMR for the whole cohort was 0.43. Again, not a surprise, given previous studies and the very, very healthy selected population. Compared to the US population, and you can see compared to New York State, SMR is a little higher. And that's a good question. Why? Why would that be? Yeah. Probably a lot of explanations for that, but at least there is some variability depending on your comparison population. And the cause of death compared to the two reference populations, and we were concerned about lymphatic cancers. That was one of the thoughts, and it has a relatively short latency. And is there an effect? Well, the observed over the expected, the SMR was 0.96 compared to US and 0.96 compared to New York State. So that's pretty much close to unity. Disease of the heart, of course, we'd expect to be very low, and again, indeed it was 0.39, 0.41. So heart disease, very, very low in this population, and violence was another thought we had, but it's, again, it's actually very low also. So I'm sorry, the slides are a little bit off kilter. And we looked at sex, and as you'd expect, males had a higher risk of death, about 1.77, is statistically significant compared to the women, even though the women are a relatively small portion of this population. It's the males always die more and earlier. In every study probably that's ever been done in occupational apathy. We're looking at race ethnicity. Again, no surprise, the non-Hispanic Black population is at risk. They have about a 1.28 all cause, and then specifically heart disease and smoking related were statistically increased. So smoking and enrollment, I'm sorry the slides are a little bit off, but there's an effect on smoking. Also, smoking is highly significant as a predictor. Then we looked at data for first arrival. You can see that there's no effect of data first arrival in the FDNY population, GRC population, but the registry, you can see there's statistically an effect of early arrival. on our World Trade Center registry population. And I don't know why that is. Partly it has to do with, the registry is a much more diverse population, and it includes a lot of volunteers, people who may not have been may not have been in an occupation before that or was trained. So they just spontaneously showed up. They were not associated with any organization. So they probably had fewer protective measures, probably had less things that would normally protect them. You can see that it's true for 912 as well. There's an effect of all cause and also smoking related. So overall, what we have is all cause and cause-specific mortality were lower than expected compared to the US and New York State populations. But there's some increased mortality risk, particularly for the World Trade Center Health Registry folks who were there early on and worked on the pile. Male pile workers had increased all-cause heart disease and cancer-specific as well as smoking-related mortality. So we're beginning to see a pattern here, even 15 years after 9/11, that there was an effect probably on mortality. We're not able to see it yet in a general sense, but there is some clue that maybe there's something going on. I don't know if you disagree, but is there a reason to continue? Well, first of all, this is again an example of healthy worker effect. What would you expect, among first responders? Well, there are people who are screened, as I mentioned, they have job requirements to get into the population. So they're probably going to be healthier. There's something called the healthy worker survival effect. People who are working compared to the general population, when you have people who are disabled, not able to work. That's another indication of the healthy worker effect. And there are advantages to work. You have insurance, you have other things that probably influence mortality. There's a comparison between the cohorts. So that does give us a clue. Because of the very variability of the different cohort exposures, we can see which things might actually be a thing to be concerned about. FDNY, of course, had the lowest rate of mortality. Now we have also SMRs can underestimate the true relative risk of exposure because of the comparison to the general population. So why should we continue? Should we continue mortality? Well, that's a question someone is going to have to answer, because right now we're all kind of at risk of being defunded. So is there going to be another study? That's the question. Should there be another study? How many people here think that we should continue, or have we already learned enough? Anybody think we should stop? Yeah, it's hard. It's hard to say. I mean, we know that there are probably going to be effects because we can see the trends, but it's really incumbent on somebody to take the data they've collected and actually do a future study. So I'm hoping somebody will be available to do that in the future. Okay. And acknowledgements. These are all the people, a lot of people here at Mount Sinai, and Paul Buffetta and Charlie Hall were the principal investigators, kind of led this project. A lot of other people contributed. So it's one of those rare opportunities where you have institutional collaboration across many diverse groups of researchers. And it was a great experience, I must say. Really am glad I was part of it. And thank you very much. Any questions?